Hello, today we're going to talk about deconditioning in hospitals. On this slide, there is a link to an example of patient or consumer information about deconditioning that was developed by Recondition the Nation, NHS. So we know what deconditioning is, but it remains improperly defined. And literature is extremely large, very diverse, and incomplete. The diagnostic criteria for deconditioning is not particularly agreed upon. There are no consistent patterns or progression symptoms. They're all very different. It is called hospital-acquired deconditioning, so HAD, and today's presentation looks at causes, physical effects, psychological effects, prevention, barriers, and literature. But think about it. There really is no economic, functional, social, or caring reason or sense to allow patients to decondition while in hospital. So I hope by the end of this presentation, you will have identified something that you can put into practice. This is the deconditioning cycle. So bed rest then increases the risk of falling due to weakened muscles. There is increased confusion and disorientation. This could also lead to constipation and incontinence, potential UTIs, or a fecal syncope. Decreased appetite and poor digestion, so at risk of malnutrition. Increased risk of swallowing problems, so increased risk of aspiration pneumonia. Further immobility, and then increased risk of infection and further decline, leading to more bed rest. So deconditioning is a little bit of a cycle. So understanding deconditioning is really important as it directly affects the recovery and the well-being of the patient. While there is no specific definition, it is referred to the physiological and functional decline due to inactivity of bed rest. It includes loss of muscle mass, strength, and independence. Hospitalized patients often complete less than 100 steps daily, and they spend over 90% of their time sedentary, and this then exacerbates their condition and exacerbates deconditioning. 30% of older adults who experience deconditioning during or following a hospital stay, and that's important to remember, the following a hospital stay. People are still unwell when they go home. They're still fatigued, they may still have health problems that lead to them needing to rest. So that deconditioning may well continue while they look to gather their strength and to become enter life again, to start to become more social and to be able to look after themselves. There are long-term consequences, so deconditioning impacts recovery, and it can lead to increased vulnerability and frailty and risk of falls and heightened healthcare costs. There's many causes, but prolonged hospitalization is one of them. So extended stays leads to physical activity. Chronic illness, which may necessitate immobility, along with those natural aging processes. And environmental factors, so medical environments are often lack sufficient support for maintaining mobility and physical activity. And then that contributes to sedentary behavior. So for example, if you perhaps look at the corridor of your ward in the morning, you see all the team is out, so there'll be lots of medical staff around, there'll be beds being pushed here and there will be nurses going about their duties, there'll be OTs and physios doing patient assessments, and for the physio, that often involves walking a patient down the corridor. There's lots of clutter, There's lots of things happening, and I've had patients say to me, I want to walk, but I can't walk in that corridor because I'm frightened I might be knocked down. So we need to think about how can we help our patients? How can we get the environment to be safe so that they don't have a fear of mobilizing? So who is at risk? Those that are older, those that have delirium and multiple comorbidities, uh, poor mobility or use of an aid, those that suffer with depression, they have deficits in their ADLs at hospital admission or at discharge. It can be exacerbated by fear of falling, and we do tend to tether patients to beds with IV drips, IV hydration, medications and catheters and various other equipment that patients require to get well. May necessitate them staying in bed because you can't walk with a CPAP machine. And healthcare staff, they prioritise patient safety over patient activity. And this is where you have that look at, you need to balance between duty of care and dignity of risk. So the physical effects of deconditioning include muscle atrophy, so that's a decrease in muscle mass and function, bone density loss, increased risk of fractures, cardiovascular decline, there's a reduced cardiovascular fitness and function, respiratory issues and a compromised lung function and breathing difficulties, and reduced balance and mobility, which is going to lead to a higher risk of falls and accidents. So there's not only physical effects, but there's psychological effects as well. So there can be emotional distress. So people often experience depression and anxiety due to inactivity, and that can make it quite challenging to engage in the recovery process. So people who are feeling depressed, they find it difficult to have a conversation, to actually get up out of bed to do something. It's very hard for them to do that. So we need to recognize that this patient may have depression and work out a way to enable them to engage in exercise or sitting out of bed or any type of activity. Deconditioning leads to social isolation, and you can lose your self-esteem and your confidence while you're performing daily activities. And cognitive impairment. So heightened stress levels lead to decreased cognitive function and affects the patient's ability to comprehend and follow rehabilitation instructions. So how do we assess for deconditioning? So this study here looked at multiple literature, systematic search to try and find an assessment for deconditioning for HADS, but there is no comprehensive time-sensitive assessment or instrument. And currently, each member of the multidisciplinary team completes their assessments and then would bring it in to a team meeting to discuss further. So what this study shows us is that these are the items to assess: muscle strength, aerobic capacity, vasomotor stability and balance, skin integrity, pressure injuries, mobility, ADLs, walking distance, gait speed, appetite, and incontinence. It doesn't actually say anything about falls, but I am going to add that in there. So we do need to assess for falls. Assessment measures. So these are some of the things that you would do for assessment. So rising from the chair, turning and or sitting down again, how far a patient can walk, pressure injuries, a mid-arm circumference and calf circumference, climbing a flight of stairs, picking something up from the floor, walking backwards, jumping and standing balance, bed mobility, ADLs, appetite, and continence. These are some of the actual tools that we know about that you can use and are recommended from this literature. Together, they bring a complete picture of the patient's hospital-acquired deconditioning. So you can use your timed up and go, your physical performance test, the Dartmouth cooperative function charts, nutritional screening, short physical performance battery, De Morton mobility index, activity measure for post-acute care, continence assessment and skin assessment. And again, falls isn't mentioned, but I'm going to add it in here because multifactorial falls risk assessment will look at some of this, but not everything. And a multifactorial falls risk assessment, I think, is a good tool to add in here. How do we prevent it? Bit difficult in an acute hospital. You know, I have to think, well, what could I do in an acute care hospital, which is a very challenging environment? Patients are acutely unwell. So what can we do? Really, one of the key things is early mobilization, and that doesn't mean that they have to run off down the corridor and run a marathon, but it could be just as simple as getting out of bed to start with regularly, perhaps walking halfway to the toilet and then going in the chair for the rest of the way, and gradually building up from there. But early mobilization is key. Making sure that they've got adequate nutrition is extremely important to maintain that muscle mass and ensure that they have the energy required for that increase in physical activity. And then customizing those physical activity plans, which is what physios and OTs do based on the individual capabilities, encouraging participation and mitigating the risks. Further strategies, so a comprehensive multidisciplinary assessment to determine current and usual capabilities, complete a multifactorial falls risk assessment and ensure interventions in place to mitigate risks that have been identified. Team discussion as to how to reduce the risk of deconditioning. Make sure the patient has their sensory aids, that's very important, and their call bell is in reach, and the environment is as safe and as uncluttered as we can get it. And where the patient is able, just encourage physical activity, however small. So like I said before, get them to sit out of bed for meals, but get them dressed, get the family to bring clothes in. There's nothing like getting out of your pajamas and into be it a tracksuit or be it just normal day clothes. It does help you to feel better. Assist the patient to walk to the toilet, make sure their mobility aids are always next to them. Encourage them to move around the bed regularly. Like I say, I'm no physio, but for me, this I think would encourage the core strength, arm muscles, leg muscles, whatever you like to think. It would certainly help to prevent deconditioning. Simple exercises while on the chair or on the bed if on bed rest. Do see the Move It May exercise leaflets. I've got those on the presentation a bit later, but check with the physio first. But for the most part, if the physio agrees, these exercises can be done by the patient by themselves. Ask the family to bring in some reading materials, puzzle books, headphones, music, anything that will keep the mind occupied. And in partnership with the patient, set some activity goals. So sit out of bed for lunch each day for the next 5 days, or I'm going to walk to the toilet one way, and then build it up from there, review and change the goals as they're met. Ensure the patient is not malnourished and allow the patient to maintain as far as possible a normal sleep routine pattern to reduce that daytime fatigue. I guess this is all of that in a bit of a nutshell. So provide education to the patients and the caregivers, but also to the staff so that they understand deconditioning. Goal setting is important and increasing the intensity of activities. Ward-based environmental changes, so seating in the corridor, bring patients together in 4-bed rooms, so perhaps put them just where they can easily talk to each other over a cup of tea. Allocate rehab time for activity. Have a dedicated walk assistance or a local champion. In some hospitals in other countries, I know that they have volunteers that do this, but certainly it's something to be thinking about. It would be great. And to support that behaviour change, so positive reinforcement. And the consultants are often key for this. So a lot of the older people revere the consultants, and so them saying to the patient, that's really good, you did great today, it's lovely to see you up and dressed, it really is, can go a very long way to reinforcing positive behaviour change. Of course, there are barriers to hospital mobility. It can be very, very difficult to understand how to get people moving or to do things that will increase any physical activity. And it doesn't have to be walking. So, bring patients together just to bat a balloon to each other for 5 minutes or to talk to each other. There's lots of different very easy, resourceless games that don't take very long that certainly will increase that patient's activity. So the barriers, it could be patient related, so the illness severity, comorbid conditions, altered mental status, pain and fatigue. Treatment related factors, so it could be hospital devices, like I say, IV and catheters. There could be side effects of medications that might be preventing people from moving. Staffing, institution-related factors, so staffing and an environment that encourages bed rest, a lack of ambulatory devices, perhaps lack of opportunity, and attitudinal factors, so perhaps an attitude towards mobility, the expectation of hospital stay. Some people, perhaps their expectation is that they stay in bed until the day they get discharged. And concern about falls, not just the patients, but as we said earlier, the staff may well have a fear of the patient falling, and that can impede reconditioning. So patient information, and my question to the presentation was, does any hospital have a patient information leaflet about activity and exercise while in hospital? This one here is for Move It May. It's not specifically for hospital, but it will provide much information. This is why we have a Move It May. It shines a spotlight on deconditioning and its ramifications. It encourages and supports activities and research and quality improvement initiatives on prevention and on treatment. WA Health Older Persons Network fully supports this, working with the hospitals, clinicians and researchers and consumers to continue to deliver optimal evidence-based care for patients. So we have other programs and resources. So we have Move It May. We have Eat, Drink, Dress, Move. Now that was presented by Jackie Holmes last month, and that presentation is on the YouTube channel. NPJ paralysis, this has been going for a few years. This is from Brian Dolan, who first initiated really about deconditioning and woke us all up to the effects. Eat, Walk and Engage is a Queensland project. Recondition the Nation is an NHS project which works very hard and works with multiple outlets to try and encourage activity in patients. In a couple of weeks' time, they do actually have an education session. So if you want the email of the organizer, just let me know. And there's something called Get Up, Get Dressed, Get Moving. Again, it's the same thing, just a slightly different program. And then there's the British Geriatric Society, which has a whole wealth of information and resources on deconditioning. Physio in the Sticks has information for consumers and for staff on the effects of bed rests. Sonia does these amazing posters on various different topics, but on MPJ paralysis, and her email address is on there if you would like to use any of her material. And then the American Association of Post-Acute Care Nursing also has a section on deconditioning, advising nursing staff what they can be doing. So these are some of the Move It May resources. These are the exercises, lying down exercises, and for many patients they should be able to do these on the bed. These are simple seated exercises. Again, check with your physio, but most of the time the patient should be able to manage these themselves. And simple standing exercises. So these are all available from the Move It May WA Health website. We also have the Move It May playlist, so the Spotify playlist. So if you have favourite music, you can send it through and it'll get uploaded, and then you can use the Move It May playlist for exercise, for activities, as background music, whatever you would like. So do consider sending in your favourite song. So it's really important, I think, that as we wrap up our discussion, we emphasise recognising deconditioning as a significant healthcare concern. It certainly increases the risk of falling and has many other poor outcomes. But addressing it early can lead to better patient outcomes and an improved quality of life. And our understanding of its effects can enhance patient care protocols. So by learning more about this, are we doing enough? What can we do that's different? What is the literature saying to us? How can we improve practice for the patient? So in conclusion, the importance of addressing deconditioning cannot be overstated. It impacts not only physical health, but also emotional well-being. Let's take some actionable steps to implement our various strategies. Thank you so much for listening, for your participation and engagement today. Thank you.